devices.
Dance floor, so yo, what's up? Hands in the air, come on, say yeah. Everybody over here, everybody over there. The crowd is live and I will do this fool. Party people in the house, move. Sweat till you bleed. Is that dope enough? Indeed, I paid the price to control the dice. I'm more precise. To the point, I'm nice. The music takes control. Your heart and soul unfold. Your body is free and behold. Dance so you can't dance, so you can't dance no more. Get on the floor and get raw. Dip, come back then upside down. Easy now. Let me see you move.
Welcome to the Health Innovation Summit. The session is about to begin. Please take your seats and silence your electronic devices.
There's a great scientific discovery. It's not one moment that defied possibility, or one point that changed everything. It's many. A miraculous breakthrough only comes by risking failure over and over. Increasing our potential to improve patients' lives means we never settle. Transforming the practice of medicine demands going all in on artificial intelligence. Every day, our team rises to the challenge to pursue what once seemed impossible, to lead innovation in clinical trials, and to break down barriers for those who need it most. These moments may seem small, but to our patients and their families, these moments are immeasurable.
From cell therapy to robotic surgery, we're leading the way in healthcare, harnessing our strength in both medtech and innovative medicine to drive progress across the full spectrum of healthcare solutions. We're building a world where complex diseases are prevented, treated, and cured, and where solutions are personal. Every day, we profoundly impact health for humanity. We are Johnson & Johnson.
Good morning. Once again, please welcome to the stage NCQA Senior Communications Advisor, Andy Reynolds.
Good morning. Welcome to the third and culminating day of our conference. The moderator of our morning panel has logged 3 tours of duty at NCQA that, taken together, mirror the evolution of the quality movement. Eric Schneider's first tour of duty at NCQA was almost 30 years ago. As a young physician on fellowship, his writing and research at NCQA speculated. He observed measurement process is relatively new. This thing called the internet and digital technologies are definitely new. What if measurement process and digital technology got together and had a baby? What might digital measurement mean for quality someday? Eric went on to lead at other institutions in the quality universe, including the Commonwealth Fund. While there, he clocked his second tour of duty at NCQA, and that was as the chair of the influential advisory committee that approves HEDIS measures. That's the Committee for Performance Measurement. For his third act, his third tour of duty at NCQA, that young doctor is back as the top doctor, Executive Vice President at NCQA's Quality Measurement and Research Group. But now, that speculation of his from all those decades ago about digital measurement, he's here making it happen. It is real. Please welcome, along with this panel, Eric Schneider.
Wonderful. Thank you, Andy, for that kind introduction. I feel like something of a historic relic at this point. Good morning, everyone. I'm Eric Schneider, the Executive Vice President for the Quality Measurement Research Group. We oversee NCQA's quality measurement activities and HEDIS, which covers primary care, preventive issues, health equity issues, behavioral health issues, and chronic care management issues. And as a primary care physician, I actually was responsible and tasked with integrating and coordinating care across all of those areas to improve the health of individual patients. And if you've ever delivered, managed, or paid for care, you know you too have been engaged in quality and equity activities. And like me, you probably wondered at some point, are all of the organizations, clinics, institutions, payers around me on the same page in terms of driving quality and equity? The movement to improve quality really began with asking whether our fragmented delivery system organizations were really meeting the needs of patients, families, caregivers, and others. Today, a key question is whether our care and payment models are keeping up with the new virtual technologies and other payment models that are available to improve care. So this morning, I am joined by a wonderful panel to explore these issues of emerging care delivery models and how to reimagine and shape the future of those models. So I have three wonderful leaders in that area. First, to my left is Susannah Bernheim. Susannah is the Chief Quality Officer at CMMI, the Federal Center charged with developing and testing innovative payment models, and acting Chief Medical Officer as well. Next is Dr. Douglas Jacobs, who is Chief Transformation Officer at the Center for Medicare, the nation's largest payer, obviously a big driver. And to my far left, Dr. Nisha Basu is Chief Clinical Officer at Firefly, a provider organization that integrates a commercial payer to deliver virtual care technology, use virtual care technologies to deliver person-centered, integrated primary and specialty care. So this is a wonderful panel, and we have a fairly limited time here, so I'm going to dig right in. So the first question I wanted to pose to Susannah is, can you describe how some of the recent care models and programs or initiatives have been engineered to meet some of those objectives I referred to earlier, improving quality, improving equity, and access?
Yep, very happy to be here. Thank you for inviting me. I'm going to say just a word about the Innovation Center at CMS itself, because that really drives a lot of the answer to the question, and then I'll talk about two of our recently announced models. So the Innovation Center was established as a part of the Affordable Care Act to test new payment and service delivery models to see if we could improve the quality and outcomes for Medicare and Medicaid beneficiaries while holding down program costs. And models that are found to be successful at that can be expanded in scope and duration. The models are very heterogeneous. Some focus on clinical conditions like kidney disease, some are focused on ACOs or primary care practices, some are statewide models. And they have a pretty far reach at this point. In 2023, this is where I get to look at my notes, 116,000 providers participated in our traditional Medicare models with more than 7.3 million Medicare beneficiaries, and over 1.4 million Medicaid beneficiaries receive care from a provider or a plan or an organization involved in our models. When we think about the newer models that have come out in these questions of equity and access and quality, a lot of our focus has come out of the strategic refresh that came in 2021, where we took a look back at the 50-plus models that have been developed in the first 10 years and set a new vision and strategic objectives. And I'm going to just mention two of those strategic objectives that are really relevant. One is driving accountable care. So a real focus of our work in terms of access has been to meet CMS's bold goal of having 100% of traditional Medicare beneficiaries in an accountable care relationship by 2030. And that means that patients have a person with a longitudinal relationship responsible for both cost and quality. Another key strategic objective was around equity. We have a number of pillars, but really thinking about models that themselves drive more equity, building factors into those models such as health equity plans, data collection, but also making sure that we're diversifying the kinds of providers that come into our models and that we're supporting them often with adjusted benchmarks, for instance. So you'll see some of those features in the models that I'm going to talk about, but it's really that strategic refresh that drove the choice of these models and that drives some of the things you were asking about. So the first model I'll talk about is innovations in behavioral health. This model has not actually launched yet. We'll be announcing the states that are participating in December, next month. But this is a model that aims to test value-based payment approach aligned across Medicaid and Medicare, really aiming to integrate behavioral health and physical health and addressing social needs for patients with moderate to severe behavioral health needs. And this focus on integration technology is really a key, which I know is another theme of this panel. And so the model includes a fair amount of both time and resources to invest in technology to enable this integration and this bridging of behavioral health and physical health that we're hoping for. The award recipients are actually state Medicaid agencies, and then those state Medicaid agencies will have select specialty behavioral health practices who will also receive some investment funding to advance things like EHRs. I'm going to be very brief. The quality strategy focuses on both physical and behavioral health. It also looks at reducing unnecessary utilization, and equity is key, in part just on the basis of the population we're focusing on and the Medicaid focus, but also includes requirements for things like screening and addressing health-related social needs. I'm going to move on briefly to the Making Care Primary model, which is just a different example. This is part of a portfolio of models we have at CMS that are really trying to strengthen primary care infrastructure in the country. And we're focused on creating multiple pathways, which is a lead-in to something that Doug is going to talk about next. In Making Care Primary in particular, we're trying to create a pathway for providers who may not have been as engaged in value-based care. So there's a number of tracks where people, where providers, health clinics or healthcare providers take on increasing prospective payment as a way to have more flexibility to redesign care. It also has a very strong focus on primary care and specialty integration, supporting e-consults, creating a new code for co-management between primary care doctors and specialists. And it has a strong equity focus as well, not only incorporating FQHCs, but also incorporating health-related social needs and things like that. And I think fundamentally it's really about creating access to value-based care for populations where that has been much less a part of the landscape. And I will stop there.
That's great. Thank you, Susannah. The models, a lot of models, reflecting the complexity of our healthcare delivery system and the broad scope of things, different settings across the United States. Nisha, I wanted to ask you a question about, this obviously is a imperative to sort of try to align the provider and the payer incentives around better care delivery. And Firefly, your organization, has been really working in that area. Access has been a real significant issue, especially for behavioral health services, primary care services, and even other services. But I wondered if you could talk about Firefly's approach to access, just in relation to what you just heard.
Yeah, so, you know, so first of all, thank you everyone for coming on Saturday morning. It's such a great turnout. I get to be the one up here to represent both a primary care provider group with integrated behavioral health and also a payer, a commercial population payer. And, you know, a lot of what we have learned and helped build at Firefly actually came from lessons that we learned from best practices from the Medicare population, because as we know, there's not as much experimentation in the commercial payer and care delivery space. So, you know, I think a lot of the things that you, the programs that you're working on and have worked on over the last, several decades, right, with CMS and CMMI have been really instrumental in helping us define what does high quality primary care look like. And a crucial component of that, and one can say the first component of that, is access. And so Firefly, we are a virtual first primary care provider in 50 states, and we do have that integrative behavioral health and the collaborative care model. We started 6 years ago, and one of the things that we learned very quickly, because we actually had a brief in-person clinic, and we started with telehealth and in-person clinic, and we let patients choose, is that patients were choosing because of the accessibility to see us only virtual. This is pre-pandemic, y'all, 6 years ago. And we started in Massachusetts, people on the islands, Western Massachusetts, pretty far away from our clinic located in Boston, were choosing, this is the care that I want, because this is what works for me, and this is what works for my family in my life. And so we think of access in many different domains, and we roll them all up in our operations and our offering to our patients and members. So access, of course, is traditional, like, can you get into a visit, right? That's how we think about access, third next available, those type of things. And we monitor those things. We offer same day, next day appointments. The next is hours, right? How many times do we hear, for the providers in the room or even just ourselves, that people don't have time to go to the doctor? I know where I used to work, people would drive 2 hours, park in the garage to see me for 15 minutes. Not a really great use of their time, nor respectful to that patient. And so access is hours, providing hours before the traditional workday, after the traditional workday. Virtual clearly is an important part of that part of the access, because then you reduce travel time. People can get the care they need while at work, while caring for their kids, those types of situations. Next is access to the care that they need. Someone that will listen to them, that they feel comfortable with, that has time to take care of them. So time is really important. We are a value-based organization, so thankfully RVUs and minutes spent with the patient are important from the sort of macro point, but they're not in the lexicon of our providers, because we've engineered our practice so that we can provide that access to the patient to make them feel heard, seen, and only then can you take care of their needs. And the last is also, I wouldn't say it's the least important, but it's the one that I think is also pretty familiar, and we've heard a lot about at this conference, is making sure that we provide culturally competent care. Not just we want the language, but also, when you're providing nutrition advice, making sure that it is something that resonates with that patient and their family in the way that they want to receive that information. And so we think of access in many different domains, and we've sort of wrapped them all in to the way that we are delivering our healthcare, and then also the way we're delivering our health plan as well.
Great, thanks very much, Nisha, that's great. I'm going to follow through on that access and virtual modality to ask Doug a question. I saw CMS published a physician fee schedule rule last afternoon. Congratulations on that accomplishment. That's over 3,000 pages of regs, but a lot of good stuff buried in there. I'm wondering how CMS factored thinking about the support of virtual care modalities, telehealth, into as part of that. I want to ask you to summarize the whole.
Yeah, sure. It's really great to be with you all here today. My name is Doug Jacobs. So as a Chief Transformation Officer, part of what I do is everything that Susannah talked about in terms of the models. We use this analogy of an icebreaker. The models are breaking the ice, and then the Center for Medicare is this big, large oil tanker coming behind. And so that big, large oil tanker in rule form, I guess, is the physician fee schedule. We came out with 4 rules yesterday. The physician fee schedule was one of them, the outpatient prospective payment system, end-stage renal disease, home health. Building off of what Susannah was talking about in primary care and using the icebreaker analogy, we finalized for the first time new codes to really recognize the resources that go into advanced primary care. And we know that having a usual source of care is incredibly important to someone's overall health. And we both kind of talked about that. But unfortunately, Americans are reporting that they're less likely to receive a usual source of care. And so partly by recognizing the resource costs that go into advanced primary care, we're trying to strengthen the foundation of our healthcare system. And we're taking the lessons learned from the more than 10 years of innovation center models by really identifying what constitutes advanced primary care. And part of that's virtual care. So it's, are patients able to access care in new and different ways, in ways that they haven't accessed care before? Can they get 24/7 access to someone, even if it's not their primary care doctor, but who can later loop back with their primary care doctor or team and make sure that there's a team-based approach to caring for that person? And it's also the first time that we've actually connected coding and payment in the physician fee schedule with quality measures. And so practitioners that are billing this code will have to report primary care-based quality measures or be participating in an accountable care organization as another way to drive accountable care, like that goal that we talked about of having 100% of traditional Medicare beneficiaries in an accountable care relationship with their providers. So what differentiates these codes from other types of codes like care management and communication technology-based codes, there's no time-based requirement. So regardless of how much time is spent with the patient on any given month, those codes can be billed provided that the practice-based requirements are fulfilled. And so we're also, in the name of equity, we're paying more for patients who are dually eligible and a qualified Medicare beneficiary, because we know that it's not just medical complexity, but it's also social complexity that oftentimes drives the intensity of these services that these folks need. So we're really excited about that. In the virtual care space, there was a number of finalized policies related to telehealth. Where CMS has the authority, we've tried to extend access to telehealth. That is limited in certain ways, though, and so we also point out where Congress would have to step in to extend certain telehealth flexibilities as well. And the last area specifically that I wanted to talk about in more of the virtual care space is in the behavioral health. It is an administration-wide goal to expand access to behavioral health. And for the first time, we finalized coding and payment for digital mental health treatment. So that's the time and resources that providers actually spend onboarding a patient onto a digital device that allows them to get access to treatment for their behavioral health conditions. And we also specified that those devices have to be FDA cleared. We want to make sure that that the rigorous testing and safety standards that the FDA puts into place are adhered to. And so we're excited that this has the potential to expand access to behavioral health where people otherwise might not be able to get access.
That's great. And Nisha, you mentioned the telehealth access being really vital to the model that you're delivering. Obviously, it was supercharged during the pandemic. We really saw a major uptick in telehealth, which we thought we wouldn't see prior to that. Have you seen any, some people have postulated it's going to just sort of revert back to the usual pattern based on the fee-for-service model and the other considerations. Have you seen any drop-off?
Yeah, we have not seen a drop-off. We've seen a continued increase in the adoption of virtual first technologies. I think there are some people who would like it to drop off because then typically patients, they balk at facility fees anyway, but when they get a facility fee for a telehealth appointment, they will leave that institution usually because that doesn't make any sense. So I like that people are voting with their feet and their pocketbook. The other thing that we see is that, we see basically 3 modalities. Remember, we have a commercial population, 18 to 65, and we see sort of 3 modalities still increasing in the adoption. So one, early adopter. Some people just want the newest, coolest thing, and I think we're still pretty new and cool. And then the second are people who are just really busy. They're taking care of kids, they're taking care of their parents, they're working, and they just really can't spend that half day to go in for their annual checkup with their provider. They may love that provider. Odds are they don't have a provider. 86 million people in the United States do not have a primary care provider. And then the people who, at any age in this group, who have multiple chronic diseases, and they're spending the little time that they have going to different specialists and tests and treatments, and they need someone virtually to quarterback that care. And so our team-based model is able to actually address all 3 of those very effectively. And those are the groups that we continue to see increase adoption. The last is sort of separate from those specific use cases, which are people in rural communities. So we know that many providers are retiring all over the country, but I think rural communities disproportionately feel that effect compared to more suburban or urban communities. And so we see people who lost their providers after 30 years or have been trying for several years to get a provider and they just can't. And then they meet with us and they understand how we can meet their needs in a very different way. I think we're filling a need there. So I don't see any, we don't see any drop off in the adoption yet.
That's great. Susannah, there was a request for information on advanced primary care. Do you want to say more about what CMMI is looking for there?
Yeah, I'll just say something briefly, and I want to echo something that Doug said. There's 2 things about the advanced primary care management codes. One is this integration of learning about advanced primary care from the Innovation Center now being put permanently into the Medicare fee schedule, and the bundling of these codes that we as providers used to have to count minutes means that we really create new flexibility for providers that should give us some room to adapt how we care for patients in ways that sort of make the most sense for the patient, as opposed to sort of always needing them to count the minutes. So the RFI was asking for input on what could potentially be a next step with this. At this point, the primary care management, the Advanced Primary Care Management Code really is looking at a certain set of services, but the request for information was about whether or how CMS might consider further making primary care payment hybrid, if you will, where there would be a bigger proportion of the payment that was covered in this bundle, including some E&M codes. And really, we sought information from folks about how to do this in a way that would reduce administrative burden, would better recognize the relative resources that it takes to provide this care, that would make space for multidisciplinary team-based care, and really support primary care sustainability. So we got lots of input on that, and that will go into our and the Center for Medicare's thinking about where to move forward.
Wonderful. So I'm hearing alignment here in terms of the objectives to hybrid payment models for primary care. Nisha, the model you're in is a commercial payer mostly model because you're not living on a fee-for-service chassis, you're living on a different chassis. It seems like we're trying to migrate, and I sort of commend CMS for trying to migrate toward this non-fee-for-service based chassis. And Doug, there are other changes around accountable care organizations, and obviously that model is trying to advance the same agenda. Can you talk a bit about what's in the PFS around the ACOs?
Sure.
Alphabet soup time.
So we run the Medicare Shared Savings Program, which is the largest accountable care program in the country. About 11 million beneficiaries see a provider who's in one of these ACOs that's part of the Medicare Shared Savings Program. And it's a big part of our strategy to drive accountable care, to figure out how to grow ACOs. And there was a number of really important proposals, and then which we just then finalized yesterday, that I wanted to mention. The first is ACOs, the way that the model works is at the end of the year, if they beat their financial benchmark, they get some shared savings payments. What we've seen over time is that it's a little bit hard to know exactly how much and when those payments are coming. And so if ACOs get some additional dollars up front, they can have more flexibility to actually take better care of patients. And so we finalized a policy to allow for prepaid shared savings, is what we're calling it, where the ACO can actually get, if they've had this history of getting shared savings every year, they don't actually have to wait until the end of the year to get the shared savings. They can actually get it more up front. And provided that they spend 50% of those shared savings on services that the Medicare beneficiaries that are not otherwise payable by traditional Medicare. So that could be things like certain dental, vision, and hearing services. It could be services related to food or transportation, addressing health-related social needs, allowing ACOs to better take care of the populations they serve. And some of those services can be especially important in underserved areas to bring the equity theme in as well. We also finalized a new policy, what's called the Health Equity Benchmark Adjustment. This is something else that we've borrowed from the Innovation Center in the success of the ACO REACH model, specifically drawing in underserved providers, FQHCs, rural health clinics, and critical access hospitals. And so we've adopted this policy that allows for an upwards adjustment of the benchmark if the ACO is dependent on the ACO's dually eligible population. And so we think that this can actually draw in ACOs, in particular in underserved areas, where we really think that folks deserve access to ACOs and where we've seen historically that there hasn't been as good of access. And also, we have been thinking a lot lately about multi-payer alignment with our value-based care strategies, and part of that's in the quality space. We've finalized policies to move to the Universal Foundation of Quality Measures. These are a set of quality measures that we have either moved to or in the process of moving to across not only in the Medicare Shared Savings Program, but also in Medicare Advantage, in the MIPS program, specifically the primary care MIPS value pathway, and also across Medicaid and the marketplace. And so we think that by aligning these quality measures, there will have to be less of those gigantic spreadsheets where everybody's trying to say, okay, well, what does this payer want? What does that payer want? But there's actually going to be at least an aligned foundation of quality measures where we're folks can focus their energy. There's a lot more in the physician fee schedule. It's a 3,000-page rule. I could go on.
Thanks. Thanks for not going on.
Yeah.
Susannah, I wondered if you wanted to comment on anything that you've just heard.
No, I mean, the one thing I'll say is that when I talked about the Innovation Center in general, we have this statutory authority that if we meet a very high bar of savings and quality improvement, or at least one of them, we can expand the duration and scope. But what we're looking back and going forward particularly, we're really thinking about all the other ways that the Innovation Center learnings can be integrated into the health system. So sometimes Congress picks up something we did, like the insulin cap. Sometimes we build features of our models with Doug's team into the existing permanent program, because the models are not permanent. And sometimes we bring them in other ways. So just in the spirit of time, I'll give a tiny example, which is that we had this randomized controlled trial called the Million Hearts model that showed that when providers were given actually not that much extra funding to do standardized screening for cardiac risk and for high-risk patients to manage that risk, that there was a pretty impressive decrease in strokes and death in the Medicare beneficiaries. But for a number of reasons, that model wasn't suited for a classic expansion. So again, we then have brought into, and just finalized yesterday in the physician fee schedule, some new codes that will allow for providers to bill for both that standardized screening and management of high-risk patients.
That's great.
So it's just an example of sort of that same theme.
That's really exciting. I think one of the, and thanks for bringing up measurement, Doug. It always lights up my heart.
I knew it would, yeah.
So we've heard a lot at this conference about the burden of quality measurement, outside this conference as well, and the need to kind of rationalize that. I think one of the theories of the case for us is that measurement and improvement have become unlinked. You know, measurement and reporting seems to happen over here and improvement's happening over there. As we're thinking about the virtual care models, do we have the measures we need? Are there ways of engineering and architecting the measurement systems to better support what each of you is working toward? And I'll ask everyone to comment on that question. It's a bit of a pop question here. So.
I'm happy to start. We did not get prepared for this one. I think our job at CMS, and I see Michelle in the audience, and I'll say this was really the work of Michelle and Doug and many of us joined, was first, if you will, to clean up our own house, right? So first to sort of declutter a little bit the measures we were putting out in the world, but I don't think we have the measures we need, right? I think we're really committed to continuing to work towards more outcomes-based measures, which are harder to design and harder for providers to react to, but really ultimately tell us whether the health system is doing what we want, and I think there's still some work to do there. You know probably better than anyone, we still have a lot of work to make the data flow and the measurement enterprise to just work better from a digital standpoint. And I think your question was around virtual, and I think as much as we like to align, I think it is also really important that as we work in new spaces, we think about the risk and the opportunity in those spaces and build measures that fit with that, right? So measures serve, I think, a number of purposes, but one of them is to, especially when in our models, when we're trying to decrease payment, part of our job is to make sure that, patient care is improved or at least maintained, that there's no decrement, so the measures serve that purpose. But the other is to try to incentivize improvements, and I think when we move to virtual care, we have to think about what might be lost in that relationship, and how do we make sure that those elements of care are still there. So maybe we're looking more at patient-reported measures, maybe we're looking more at things like continuity, to sort of bridge that gap. So.
And that's great. I think also, just building off what you're saying too, some of these measures are actually useful in making the decisions that we have to make collectively around how do we think about extension of certain flexibilities during the COVID-19 pandemic. Mm-hmm. Actually, there's increasing studies coming out that are looking at how quality was affected or not affected by the switch to more virtual care modalities. And I just want to say that information is really useful to us, because we try to be evidence-based with how we progress and what we allow to go forward with waivers and what we don't. And so if any of you are part of any of institutions that are doing this research or thinking about how care is actually being affected by virtual care, I think sometimes people paint in just gigantic broad brush strokes about virtual care is always good. And there might be certain circumstances where that's not the case. And so quality measures, I think, can actually be that way that we do that evaluation about what should continue, and what should we think about in the future about like changing the way that care is delivered to get to this future of better care, better access, better equity.
That's great. Nisha, I see you nodding.
Yeah, I completely agree. Not all virtual care is helpful and or high quality or safe. And so that's something that we think about a lot in our model, and making sure that we don't go into those pitfalls, such as there's a great study that came out, I think it was last year, that showed that when someone has a virtual visit with an urgent care provider that is not connected to their longitudinal care, they have 3 times higher incidence of going to the ER in the 7 days following that visit. That's not great care. Something was missed that drove that person to the ER. And so, I think, and then I'm going to say something spicy. I actually think that the ways that virtual care is measured should be the same as all primary care. I think it should be on 3 things broadly, and I feel like I'll get agreement when I say these. So one is, are we reducing total cost of care? That's the part of the value equation that I think we don't really have great ability to measure in most practices or spend enough time talking about. The second is, are we providing high quality care? We have 36 measures that we track. And that is a lot, and it's burdensome. We're actually starting to, those are important. Of course, we want to provide cancer screenings, diabetes care, hypertension, et cetera. Of course, we want to do those things, but we're actually sort of zooming out and thinking about how do we actually just measure the healthy days that people have. So that's almost a throwback, right? It's like 2 decades ago, and the CDC was sort of doing their investigation on healthy days. And because that to us is a much better, more tangible measure of quality, in addition to these supporting metrics, making sure that people are getting the chronic disease and preventative screenings that they need. And the third is patient experience. We use NPS for that. It's not the best, definitely has some challenges, but at least it has benchmarks that we're able to really kind of go across different industries and say, are we doing better than Apple? Great, like we're really happy about that this month. And so I feel like those are measures that should be measured in all settings of care, not just primary, but also specialty. The how you get there is different. Now I'll put a plug in for the virtual care accreditation pilot that I've been working with NCQA on, because the how is really important. So in the last year and a half, we've been working with NCQA on being one of the pilot organizations to create that virtual care accreditation program. And that has been really wonderful, because I see it as a way to actually say, okay, this virtual care program is actually meeting certain standards, and so we can expect some of these long tail outcomes that we should hold everybody to will be met, right? But we need some I see the virtual care accreditation program as really a process measure to some of the outcome measures that we're not going to see maybe for 2-3 years once you actually develop that ability to kind of evaluate the program and sort of the natural timeline of how long it takes some of those things to occur.
Great. Thank you for that shout out. I just want to point out that that was not in the talking points for this session, but we really appreciate that. You can see now this panel is really good at handling unexpected questions, and we would love the audience to participate in this discussion. So there are microphones up here. Please come forward if you have questions. And before we go there, I'm just going to ask one more about the integration of specialty and primary care, which seems to be sort of the final frontier sometimes in the way our care system is organized. Nisha, maybe I'll start with you on that topic.
Yeah, so remember, we're set up as a value-based care organization. We are trying to improve quality while reducing costs. And so one of the ways to do that is to provide fantastic comprehensive primary care. So if we give our primary care providers the time to use their skills, guess what? Referrals go down. So the first strategy that we employ is reducing referrals through providing great care. The second is, how can we meet specialty needs in more creative ways? Not everyone needs to go in person for a full E&M evaluation with a specialist. Can we use e-consults? And so I'm glad to see that e-consults are becoming more common in every setting now. We also use some vetted virtual specialty providers in situations where someone does not need an exam. And then the third tier is sometimes people do need that in-person full evaluation. And so we have an embedded navigation team to ensure that they're being guided to a high-value provider who has access, because that's important, and that provider has the information that they need to treat that patient, and the referral is done. So we follow it, we close the loop with that patient, because the referral, the specialty care is not helpful if it doesn't happen, right? So we have a three-pronged strategy, and that is both for safety, quality, patients love it, and then also specifically to reduce our total cost of care and provide the value that we are promising.
Great. Doug or Susannah?
I'll say a quick word. The Innovation Center spent a lot of time exactly to this point thinking about our specialty strategy, and have actually recently published an update on it, so you guys can read that, and I'll be brief about a couple of key features. One key feature of this is sort of how do we help primary care providers have the information they need to work closely with specialists. So we've this year started producing data from the Innovation Center that we push out to ACOs in the Shared Savings Program and our ACO Reach that represent the bundles of acute care that are similar to prior bundle payment programs, but it's for the beneficiaries that are aligned to their ACO, so they can understand something about the costs for patients that are in their ACO when they have acute need, like procedural needs, although it's also medical. And then in the Making Care Primary, similarly, we are building a data sharing strategy that allows us to share with them primary care practices what will eventually be both cost and quality data about the specialists in their region. So we're trying to build some supports in one element. We're continuing to work on things like bundled payments, but we're also really trying to create incentives for specialists to integrate. And so I mentioned that in Making Care Primary, there's a new billing code for the e-consults. There's also a new co-management code so that specialists who sort of temporarily take over management because somebody has an acute need, there's a new code that can be used under the model. So there's a lot of things that we're doing to try to sort of create that integration through data and payment, and we're really working now on how to do that in combination with the ACO models.
And, just to build off of that too, what Susannah mentioned with these new codes that they're testing in the Innovation Center, that is something that the Center for Medicare is like waiting to see if there's any lessons learned, and like if maybe in a future physician fee schedule, if that's successful, we would think about adoption. In this physician fee schedule that came out yesterday, in the behavioral health theme again, we made changes to the interprofessional consultation codes before when providers, both primary care and specialists, were billing for interprofessional consultation. There wasn't flexibilities that allowed certain therapists and counselors and clinical social workers to bill for those codes. So with the finalized changes yesterday, we made changes to allow them to bill for those codes, allowing for better integration between behavioral health and primary care, which the data really shows can be really important for the patient's overall health outcomes.
Great.
Yeah.
Thanks so much. So I think there was a question out in the audience. Please,
so
thanks for being patient with us.
Okay, thank you so much for this informative discussion. I'm Amy Burke. I'm Director of Population Health at Microsoft and a former Director of Medicare Advantage and Duals Populations at a commercial health plan. So my question is, on the advanced primary care codes that you mentioned, do they trickle down to care management at our payers, right? Because those care managers are often coordinating care for the sickest of patients, right? Secondly, then, as we think about virtual care, payers often struggle with member engagement overall, right, in these care management programs. So virtual engagement, I think a lot about in promoting of that. So just your thoughts on those two questions.
Yeah, I can start with the advanced primary care management codes. So the advanced primary care management codes, what's really nice about them is the way that they're designed is to pay for a primary care team. The individual practitioner, primary care provider doesn't need to be the one that's doing everything, but actually can be part of a team with care managers, care coordinators, medical assistants, licensed clinical social workers, community health workers. There can really can be all-encompassing. And the way that in physician fee schedule, like lingo that's called, is under the general supervision of the billing practitioner. And that is, and the other piece about this too, you mentioned on the payer side, what's nice about coming out with a code that does this, or codes that do this, is that not only can Medicare now pay for this, but it sets the stage for commercial payers to pay for this, Medicare Advantage plans to pay for this, for a state Medicaid program that wanted to start paying for this could. And so if that happens, to the extent that other payers also pick this up, it can really drive alignment if primary care practices get starting to be paid in a similar way across payers, linked to quality and just with this baseline of what they need to do for advanced primary care. Yeah.
And I can take the engagement question. So the center of our engagement strategy is trust. So when our patients, so we spend a lot of time actually in the first visit listening to the patient, and that we know sort of from behavioral science that really improves the communication, improves trust in the provider, and that extends to sort of trust in the rest of the care team. And then after that, as soon as someone, like we have extremely fast message turnaround time, so patients are able to message us and chat in a much freer way than say like a traditional patient portal. And you know, sometimes we work so hard to get back to them so quickly, even though it's not, say, extremely medically urgent, but what we're trying to do is continue to build that flywheel of trust, and that builds the engagement. So next time someone calls to outreach about, say, care management or a care gap or something like that patient picks up the phone because like, oh, okay, this is my provider. This is, you know, I know they're calling about something important. And we've even extended that, even though our health plan only members who don't get the care from us, you know, they may have a different relationship with us, but we extend that that feeling of being able to have them trust us and follow, and the really simple thing of just like following up as an organization on the things that you have promised that person, that helps drive engagement. We'd also have a traditional outreach program for members who don't respond to that, and we're able to use multiple modalities to enact that outreach in ways that are successful to driving them to the care that they need.
Great. We have time for one more question, please.
Thank you so much. Good morning. My name is Yvonne Burgos. Are we still morning? I don't know. My name is Yvonne Burgos. I am from Baptist Health Quality Network, Baptist Health South Florida. And so I manage the quality for both the MSSP population and our payer environment. So we have a little bit of everything. We touched on patient experience, and we touched on a little bit of access of care. What I do notice is that even in a payer environment, including our MSSP, scoring, we do have a heavily weighted on patient experience. So for example, access to care, how easy was it to get an appointment and how long did you wait after that appointment was scheduled? I kind of feel that it's not really bringing in what we have currently as our latest models, as in virtual care, patients also being seen within the primary care setting by a nurse practitioner. And so we have a lot of challenges with our physicians today where access of care is being addressed, but not necessarily with the primary care physician, but within the primary care center. Do we seek in the near future those questionnaires being kind of addressed to more the latest models?
Great question.
It's a great question. Do you want to start?
You should probably start.
I mean, I'm not sure I'm going to directly answer your question, but I just want to say a piece that I think is really at the heart of it and relates to a lot of what we've been talking about, which is, you know, what does access mean? What does continuity mean, right? What do we think a patient needs to get the most out of a relationship? You know, maybe it doesn't need to be in person, but does it need to be consistent? Does it need to be the same person, or can it just be at my clinic? And I actually was just literally in a kind of heated conversation about this because I don't think we know the answers completely. And so I think what you're raising that I don't have a good answer to is that maybe our surveys that are trying to understand whether we're succeeding don't reflect the kind of complexity of what it means to, as a beneficiary, have the, if you will, the right kind of access. I don't know of a plan to change those surveys right now, if that was the heart of the question, but I think it's something we need to continue to understand and build as we test all of these things in terms of what's the right amount of sort of access to the right person so that you feel like you have that trust and continuity.
Wonderful. Well, that's actually a great place to close because I think what you've heard now is three physician leaders in quality, access, and equity innovating and looking for ways to promote innovation, support innovation. And it's a journey that we're really still at the beginning of in many ways. And the questions suggest that there's a lot more work for us to do. I feel very confident that with this type of leadership, we will get the innovations we need, and we are moving forward and making progress. So I want to thank, please join me in thanking our panelists today. And with that, the pavilion downstairs, there's ongoing show there, probably some food and coffee, refreshments, other things. And there's, please enjoy the rest of the conference. Thank you again for your attention this morning.
Walking in Memphis, but do I really feel the way I feel? Saw the ghost of Elvis on Union Avenue. Followed him up to the gates of Graceland, and I watched him walk right through. Now security, they did not see him. They just hovered around his tomb. But there's a